افشین فرغانی هستم. چهارشنبه شب خوبی براتون آرزو میکنم. امیدوارم خیلی خسته نشده باشید امروز و خلاصه مثل هر هفته باز در خدمتتون باشیم کنار همدیگه. این هفته سعادت اینو داریم که در خدمت خانم دکتر بهاره سمیعی سریر باشیم، گاینکولوژیست و obstetrician مقیم سیدنی و بختیارمون بوده و ایشون با تمام به هر حال کمبود وقتی که دارن تونستن وقتی رو به هر حال مهیا بکنن که ما در خدمتشون باشیم. تاپیکی که انتخاب شده در مورد ادنکسال مسز هست که خب دوستان جی پی دیگه همه آشنا هستن با این در واقع موردیه که چه بسا بعضا دیر تشخیص داده میشه به خاطر سیمتومای غیر اختصاصی خودش و بخشیش مسائل گاینکولوژی، بخشیش مسائل غیر گاینکولوژی که در واقع پلویک مس‌ها رو ایجاد میکنه و در عین حال موارد خیلی زیادی که به واسطه خیلی در واقع موجب هراس هم میشه در مورد چه مریض‌ها چه برخی از جی پی ها وقتی که با مسائل در واقع ادنکسال روبرو میشن. و امشب دکتر سمیعی سریر قراره که یک خلاصه نوری به این قسمت بتابونن و قضیه رو تا جایی که میشه روشن کنن با یک اپروچ عملی و خیلی خوشحالیم از اینکه در خدمتشون. خانم دکتر سمیعی سریر اگر محبت کنید الان تشریف بیارید با دوربین و صدا. بله خیلی عالی. آره
سلام، خوب هستید؟ منو میتونیم ببینید؟
بله عالی. خیلی خوش اومدین، شبتون بخیر.
سلام به همه دوستان و همکاران عزیز. I was just telling دکتر فرغانی که خیلی سخته که آدم به خاطر اینکه کسی رو نمیبینه فکر میکنه که نشسته داره با خودش حرف میزنه. Please put something on the chat or raise your hand or anything اگر که سوالی دارین یا اینکه یه قسمت هایی هست که میخوایم من بیشتر توضیح بدم یا اینکه یه قسمت هایی هستش که میخواین که سلاید بمونه و راجبش بیشتر حرف بزنیم. I can go back to the slides as well.
بسیار عالی. من از خدمتتون مرخص میشم و دیگه در خدمت شما هستیم.
ممنون. I'm just going to share the screen. Okay. Then, going to talk about like a step-by-step of what's the prevalence, what's the incidence of the adnexal mass, talking about what are the common finding and what are the common symptoms of the adnexal mass, what are the possible diagnoses and investigation that we should do, plus talk about step-by-step in sort of different age group like the adolescents and the pregnant ladies to say که چه چیزایی هستش که باید differently تو اونها نگاه بکنیم. talk about که management plan ها چی میتونه باشه و اونایی که احتیاج به عمل دارن چه جور عملایی ما بهشون آفر میدیم. Then the incidence of adnexal mass in the asymptomatic patient بین سن 25 تا 40 سال 7.8% of the time. In the postmenopausal ladies less, it's 2.5%. And you can see it is not that uncommon to find it cyst and ultrasound in a young lady. The clinical presentation that someone comes in is generally they present with the lower abdominal or pelvic pain. Then usually they come in with the sudden onset of the pain, and you need to know about like what are the characteristics of the pain to sort of think about what it can be. Then if someone comes with the sudden onset of the pain, you would think about rupture ectopic pregnancy, rupture cyst, is it a torsion? If someone does have a gradual increase in the pain with this like a knowing pain that they had, it's just getting worse and worse and gradually getting, you would think about if it is a endometrioma or endometriosis or if it is a slowly growing lesion. Then you would think about the degree of the pain that's causing, if it's a 2 out of 10 constant pain, if it's a pain that gets worse with the periods, or if it is a sudden onset out of the blue pain or a pain that started straight away after sex. Then you have to think about other association symptoms, such as if someone presented with a pain and a nausea, you more think about a torsion, which if someone presents with the pain and a bleeding, you would more think about, maybe it is an adnexal mass, it is an ectopic pregnancy. Sometimes they present with the finding of a mass, an examination. Then occasionally patients come in and say, oh, I found this lump, I just want to know what it is, and you do ultrasound to find out more it is. In a slim young patient, sometimes they find the mass themselves. Occasionally you find it on a general examination when you're doing a gynecological examination or palp the abdomen. It's actually, have you noticed this mass before? And many times they are the big ovarian mass. And sometimes they present because they had ultrasound for some other reason, and they're coming with this ultrasound finding that shows that there is Adnexal mass. Then, like anything else, we don't treat the ultrasound, we'll treat the patient, and we need to know a little bit more about the patient. Then you want to know about a little bit about a gynecological history. You want to know when is the last menstrual period, and you want to know a little bit about the menstrual history. Then you want to know if they have regular cycles, if they have heavy bleeding, if they have pain with the period, if they have intramenstrual bleeding or intramenstrual spotting, if they have postcoital bleeding. And you want to sort of know the cycles to see if they get the periods every 3 months, like a polycystic ovarian type, or if they get the periods quite regular, 28 days. You want to know about the contraception, obviously. If you have someone that coming with pain and a mass and not using any contraception in a young patient, you would think about ectopic pregnancy. Some of the contraception, like if someone using the IUD, you would still think about might be ectopic pregnancy because it can be more common with the IUD. You want to know the pregnancy history, sort of know if they have a cesarean section before, if they have complicated surgeries, if they had any complication with the previous pregnancies. You want to know a little bit about past medical and surgical history, and it helps you make that decision in terms of the management plan a little bit better. And you want to always know about if there's a family history of breast or ovarian cancer. Then, obviously, sometimes they come in with the ultrasound. Sometimes when you find a mass, you send them for ultrasound. What are the features in the ultrasound that you look at it and what they tell you? Then always when you have a look at the ultrasound, first you want to know the size of the cyst. Then we categorize them in less than 4 centimeter, more than 4 centimeter. Less likely, anything less than 4 centimeter, very unlikely to be a malignant case. Less likely to cause any problem, such as torsion, rupture, and less likely to cause pain. More than 4 centimeter, more likely to cause all those things. Then you want to know if it's a cystic lesion or if it's a solid lesion. Obviously, the differential diagnosis between a cystic and a solid lesion can be completely two different paths that you have a look. Then you want to know if the cyst is simple and complex, and by complex we mean if it does not have a solid component, if it does have, the cyst by itself does have a thick wall, or the wall inside, like if there's a multicystic lesion, if the wall inside are quite thick. You also want to know the vascularity to the cyst, and sometimes when you have a look at the different slides on the field, you can see that they put a Doppler and you can see if it is a wall multicystic lesion, you can see if it is a vascularity going to that wall or not, which can help you sort of figuring that is more likely to be something borderline or malignant compared to something benign. And one of the other things that you want to look at would be like a papillary projection when you have a look to see if that's a solid component there. Obviously, never ever presence of ascites is a good thing finding on ultrasound. And one of the other things you find sometimes in ultrasound report, you see that it was a tenderness at the time of the ultrasound with a probe tenderness, which then make you think about, is that infection? Is that a PID? Is that a tubovarian abscess or a torsion or ectopic pregnancy? Something that causes inflammation more than normal. Okay. I'll have these few slides about the cyst. I'll go through the characteristic of the cyst, and I would like to go back and ask you guys to think what you think these cysts are. Then this is, and I'll tell you the story about this patient. Then this is a cyst that you can see. It's a quite thick wall. It's a multicystic, and it does have this like a solid component there. We'll get back to what we think it is. This one, you look at it, it does have ground glass appearance. We go back again to talk about what this is. Then you have a look, you see these echo shadows, look like a different one. You have a look at this one. Oh, this one does have multicystic areas with quite thick wall. This is the papillary projection that you see. This is a nice, beautiful cyst with a couple of follicles next to that. And does have the writing there to tell you what it is. And you can see that's actually tubular structure. It's a tube, probably it's a hydrosalpinx. Then I won't ask anyone about this one. Okay. Then the differential diagnosis of the adnexal mass. Well, firstly, we need to exclude the urgent and possible malignant settings. Then the things that you want to rule out always, you have to make sure it is not ectopic pregnancy, you think it's not a torsion, it is not adnexal malignancy such as the ovary or the tube, and you want to make sure it's not a PID or severe tubal ovarian abscess in terms of treatment-wise. I'll go back there. With the ectopic pregnancy, obviously, you always do a beta ICG, and if it is possible, if it's the positive beta ICG and you do have adnexal mass, you always think about ectopic pregnancy. The torsion, the ovaries are not as bad as the testes. With the testicular torsion, you do have a very short time that you have to act before. The adult ovaries are a little bit more resilient, like all the ladies, and they can survive longer. Then usually you want to diagnose to make, especially in a young person, to make sure that you detort the ovaries to save the ovary. Many times we see a black and blue ovary and you detort it and you go back and have a look 6 weeks and they have beautiful blood flow with no damage to them. Then we think about ovarian masses, including it can be a physiological cyst like a follicular or a corpus luteum, can be a benign ovarian neoplasm like endometrioma, mature teratoma, which is a dermoid cyst. It can be ovarian cancer, or it can be metastatic cancer from other organs to the ovary. The commonest thing is a GI from the stomach to the ovary. It can be a mass of the fallopian tube, which we think about ectopic pregnancy, hydrosalpinx, and fallopian tube cancers. Then you think about the common things like endometrioma, functional or physiological cyst. You think about leiomyoma, which are the fibroids. Then many times when you get ultrasound, they actually describe it as a solid adnexal mass. And many times when you do better looks, send them for better ultrasound, or do a CT scan or MRI, you find that it's a pedunculated fibroid that's rising from the uterus. And because of the position, it's described as adnexal mass. And sometimes it is the fibromas, which is the solid, like a fibroid of the ovaries, and they are mainly benign cysts. Then you want to make sure it's not a tubal ovarian abscess, and occasionally you find a polycystic ovaries there. In a clinical finding, abdominal examination, you find a palpable mass, you might find generalized tenderness, you might find distended abdomen with ascites. We always do, as a gynecologist, we always do a bimanual pelvic examination. Sometimes you find in the bimanual examination, you find a mass and you find a tenderness. And on the speculum examination, you always have a look at the cervix, and sometimes you find there's a cervical polyp, then maybe it's coming from ovarian polyp, from the endometrial polyp coming out, and many times you find some vaginal lesion or cervical lesion, which is metastasized from another mass. Other investigation. Now we got the history, we did our clinical examination, we got the patient presentation, we know a little bit about the patient. What else we're going to do? We always do a quantitative beta ICG. We do a full blood count to have a look at the hemoglobin. You can use it as a marker if you think about the rupture ectopic, hemorrhagic cyst, and then you can compare to see if it's dropping fast or what was the previous hemoglobin. You always have a look at the white cell count. It goes up if it's a torsion, if it is an inflammatory process such as a PID. We love the tumor markers. Then we do tumor markers for a complex adnexal mass. I would say probably we don't do tumor markers for the adnexal mass less than 4 centimeters. We do it if they are very, very complex looking, but mainly for more than 4 centimeter adnexal mass, you do a CA125, which usually we do it to find about epithelial cell tumors. Lots of other benign things can increase the CA125, never increase it to the high hundreds and thousands, but it can increase it to 80, 60, sometimes 100. Endometriosis is the commonest thing that causes the CA125 to go up. Menstruation, I always tell the patient to do the tumor markers when they are not in their cycle, when they are not menstruating, because that menstruation by itself, it's inflammatory markers. If you do have any other infection going on, CA125 can go up. We do inhibin A and B for solid lesion, because it is one of the markers that can go up with the granulosa cell tumors. We do an AFP for rare but potential dangerous masses like yolk sac tumors, immature teratomas, embryonal carcinoma, and dysgerminomas. The beta ICG can be still characteristic for choriocarcinoma, embryonal carcinoma, and dysgerminoma, and we do a LDH as one of the characteristics to find dysgerminomas. As gynecologists, we love to do the risk of malignancy index. Then what is the risk of malignancy index? Then it is basically calculating to see what is the probability of this cyst to be bad. And if the risk of malignancy index is more than 200, we almost always send the patient to gynecologist because we think most likely it's going to be something bad and we don't want to deal with it. If it is intermittent, we're still going to investigate a little bit more, but if it is low, it is less likely to be anything bad. How do we calculate it? It is 3 characteristics. We use the number of the CA125, we use the menopause stage, then we give them number 1 if they are perimenopausal, number 3 if they are postmenopausal, and we use the ultrasound features. Then basically it is ultrasound feature time menopause status time CA125. Then for the if there's no ultrasound abnormality, we give them 0. If there is one of these, it's a lacunar cyst, it's the solid area, we give them number 1. If there's one characteristic of the complexity, if it is more than 2 or 2 to 5, you give them 3. Then automatically, if you do have a complex cyst, you give them 3. If you have a multicystic lesion with some solid lesion, you give them 3. If it's a simple cyst, you give them 1. Menopausal state, we said 1 and 3. Then, for example, if you have a 60-year-old postmenopausal lady with a large 8 centimeter cyst with multicystic areas and solid areas there, with a CA125 of 200, then you'll have 200 times 3 times 3. It is definitely high risk patient. Start going through again differential diagnosis for the adnexal mass. You think about gynecological, ovarian, tubal, extra like a paratubal cyst, and non-gynecological, and always think about the non-gynecological thing as well. It can be simple things like constipation, it can be appendiceal abscess, diverticular abscess, pelvic abscess, bladder diverticulum, urethral diverticulum, pelvic kidney, and a peritoneal cyst. And we talked about the ovarian and tubal as well. Okay, then the other 2 categories that I want to talk about before we go to management, follow-up, and operation was the 2 categories. One is adolescent and one is in the pregnancy. Then what's the incidence of adnexal mass in adolescent? It is 2.6 cases in 100,000 per year. 10 to 20% of them can be malignant. Again, the clinical manifestation that you said, people present with abdominal pain, and there's a common presentation that they have. They might come in with a palpable abdominal mass, especially in a thin, young 14-year-old girl. Sometimes they present with a nausea, vomiting, weight loss, constipation, and sometimes they have endocrine abnormality. And it is mainly because they have hormone changes of these masses can cause precocious puberty or menstrual problem. In investigation, we always do ultrasound. In those categories, we have to think about doing a CT scan or MRI as well, especially in the ones with a high BMI and not having the very good view with the ultrasound, and can be difficult. Then you can do a transvaginal ultrasound, and CT scan and MRI and other ways of looking at it. We always do the tumor markers, and the tumor markers are more specific for that age group. Then again, you think about possible diagnosis in that age group. You think about benign physiological cysts, germ cell tumors, teratomas, macrocystic teratomas. You think about the dysgerminomas, and dysgerminoma is the most common malignant tumor in this age group. Yolk sac, embryonal, sex-cord, stromal, granulosa cell, and you think about non-gynecological things. What we do careful examination, and counseling is required. You need to think about most of the young adults and with big masses, they need surgery. Then you need to carefully counsel them and talk to them in detail, and the parents, about what you're going to do. You have to think about the big picture of the fertility for future. You have to think about doing a cystectomy versus doing oophorectomy, taking the whole ovary, as well as you have to think about risk of recurrence. Other things to think about would be if you have a young girl with a cyclical abdominal pain, with the abdominal mass, and is not menstruating yet, always make sure that you have a look at the vagina, because sometimes you see this big bulge at the vagina, which is the hematocolpus, which is imperforated hymen, and clinical examination give you the key. All they need would be a small incision there, drain all the old blood, and the abdominal mass disappear within a few minutes. Okay, talk a little bit about adnexal mass in pregnancy. The incidence of adnexal mass in pregnancy is 2 to 10%. It's usually discovered during the ultrasound finding when we do ultrasound for the pregnancy. And management can be quite challenging because you're looking after the pregnancy and then you find a cyst, and pregnancy is a high anxiety. All the pregnant ladies have a high anxiety level already, and you add that anxiety up, you do have a cyst as well. The management depends on the size of the cyst and characteristics of the cyst. You think if it's simple or you think it can be borderline or something malignant. Depend on which gestation of the pregnancy you diagnose the cyst and the clinical symptoms. If it's just the incidental finding at the time of the ultrasound, or actually patient came with a pain and that's the reason that you did the ultrasound. They may lead our physiological cysts and resolve spontaneously during the pregnancy. I had many patients that I had a look at the first trimester scanning, and there was an 8 centimeter beautiful cyst sitting there, and I watched that cyst going, resolving, and you can't find it after in a second trimester. You need to have a careful review of the characteristic of the cyst and at the time of the ultrasound, and monitor the size, consider if it is malignant, and if it is something that you're going to operate, probably the best time would be a second trimester. You like to operate between 16 to 20 weeks, less likely to have a miscarriage because they're past that 14 weeks and the uterus is not big enough to, and you should be still able to do a laparoscopy. Then the suspicious, the tumor markers are not reliable in a pregnancy because all those tumor markers that we talk about is going to be raised regardless because they're pregnant. Then we cannot use them. Obviously, if CA125 is in thousands, that can be a very suspicious thing, but we know that all those are going to be abnormal because of the pregnancy. Then suspicious cyst features would be the solid component, multiloculated large tumors, increased cyst wall thickness, thick septum, multiple septums, papillary projection. Then, if in doubt or difficult to assess the cyst, MRI can be one of the things that we can use as a tool to investigate further if you're worried about it. The commonest thing would be the corpus luteum cyst, 13 to 17% of the masses in pregnancy. It can be a hemorrhagic cyst, can be a follicular cyst, endometrioma, dermoid, and most of the time the patient, if they had ultrasound before, they know about them already. Sometimes they can get bigger in pregnancy. And hyperstimulation can cause multicystic large ovaries, and they do have a high risk of torsion, especially in the first trimester. Adnexal mass in pregnancy, even simple cysts can cause problem during the pregnancy. Then what are the problems that they can cause? They can cause torsion. Then depend on the size of it, and usually it happens first trimester or beginning of the second trimester if they're going to cause torsion. They can rupture and they can cause significant amount of the pain, and occasionally they can cause enough inflammation to cause miscarriage or preterm labor. And if you do have a very solid or large mass, it can cause obstruction in labor if you get diagnosed in the third trimester or it doesn't get managed during the pregnancy. Okay. For all the cysts, in terms of the management, then we would need to know, okay, who do we send to emergency department? And if you do have a patient symptomatic with ectopic pregnancy, these days, every single hospital, especially every public hospital, they have early pregnancy assessment clinic for early pregnancy complication. Then if you do have a ectopic pregnancy diagnosed on ultrasound, which patient is completely asymptomatic, pain-free, we always send them to early pregnancy assessment clinic because they can talk about different options in terms of medical, surgical option, and much less waiting for the patient and dedicated gynecology team to look after them compared to them coming to emergency. But all the symptomatic one, they go to emergency department. Then obviously if someone does have a significant pain, you need to go to emergency because you think about a torsion or a rupture. If someone is febrile with significant pain, you want to send them to emergency for the PID screening as well as getting the appropriate antibiotic treatment. Then who do we send to the gynecologist? We send the patient with a complex or large cyst and anyone with a risk of malignancy index more than 200 or intermittent risk for gynecological assessment. One of the other things is conservative management. Then who do we repeat ultrasound and just do the follow-up if they're asymptomatic? Get ultrasound for other reason and there's a 4 centimeter cyst, looking simple, no problem at all. Then you can do conservative management. So let's repeat ultrasound in 3 months to see what it is. Give them a good time. If they're simple, less than 4 to 5 centimeter and tumor markers are normal, you can easily repeat the ultrasound and wait and see what happened to that cyst. Okay, the treatments. Then we have medical and surgical option for the treatments. The medical treatment, like using the combined contraception pill or the progesterone options, are valuable treatment for small cysts, which they're causing irregular cycles or they cause dysmenorrhea. And you would think maybe it is a small endometrioma or just a simple physiological cyst that cause hormone imbalance, and you give them a trial of a contraception pill or a progesterone therapy. The polycystic ovarian syndrome is another one that we use contraception, or we use a medical management to control the symptoms as well as control the cyst. Then surgical option is probably this approach that we use a lot for adnexal mass, because most of the time we don't know what's going on. Then we do it always for the symptomatic patient with a pain. We do it for large cysts. We do it for complex cysts, and all the suspicious cysts for malignancy or borderline tumor, they would need surgery. Okay. In terms of now we decided that we're going to offer surgical management. How do we approach them? Then there's two ways of doing it. It's obviously laparoscopy and open surgery. Then how do we think about who is good for laparoscopy, who is good for open surgery? It depends on the size of the cyst. Obviously, if you have a 20 centimeter cyst that is getting the whole abdomen and you don't have anywhere to put your cameras, you better do a laparotomy. If it is a 7 centimeter cyst with a good access, then do laparoscopy. The advantage of the laparoscopy, like any other laparoscopy that we do, is a minimal invasive surgery with a good recovery, minimal pain afterwards, and much better outcome for the patient, but we have to reserve the laparotomy for the cases that we need. Then if you have a solid lesion, most likely we do a laparotomy, because you have to not only think about how you're going to do the surgery, you have to think about how you're going to get the specimen out. For anyone that is a possibility of the malignancy, we do a laparotomy because you want to minimize the spilling, you want to get the specimen out intact to make sure that you're not upgrading the cancer. Other things that you think about is the BMI, how I'm going to approach it, and if they have any other surgical risk factors such as previous multiple laparotomies or previous PIDs, you would think about what is the best approach for that patient. We think about, okay, when do we do cystectomy versus oophorectomy? Then when do we offer just removing a cyst compared to when do we offer doing oophorectomy, removing the whole ovary? Then obviously when we do have a simple cyst, we would prefer to do a cystectomy. Much easier, reserve the ovary, and it's a simple operation. We would prefer to do a cystectomy in a younger group of patients to preserve the fertility and make sure they don't lose the ovary. You need to consider risk of rupture and risk of the recurrence when you're planning for a cystectomy. Then if it's a cyst that you cannot afford rupturing it, you still can do oophorectomy, put it in bag intact and doing it laparoscopically, but you have to make sure, but with doing a cystectomy, obviously slightly increase the risk of rupture because it's a little bit out of control. The ones that are above 40 to 50, most of the time we consider doing oophorectomy. It's a fast, quick operation, plus you get the whole specimen intact in a case of coming at anything borderline, you haven't spilled anything. When you're doing oophorectomy, in these people that they don't have any more fertility desire, consider doing a bilateral self-injectomy at the same time as opportunistic thing to reduce the chance of ovarian cancer. We always offer peritoneal washing. Then we do a cytology, like put a little bit of the fluid, wash the peritoneum to make sure that there is no cancer cell there. And usually we do it for all the complex cysts. Then while you have the camera there or where you're operating, we always have a look at the upper abdomen and everything else. You have a look at the omentum, you have a look at the other ovary. If anything suspicious, you take a biopsy. Sometimes we do a frozen section, which you calculate the risk of malignancy index is low, you're happy, you go in and you find completely different story where you're there and looks a little bit suspicious. You can do a frozen section, take a sample, send it to the lab, and they can give you a result to say, okay, if you need to proceed with a bigger operation or you need to call the gynae oncologist. Okay. What do we do in terms of the follow-up and recurrence? The recurrence depends on the type of the cyst that they have. One of the things is ensure that we do a complete cystectomy, because if you don't remove the whole cyst wall, there's a high chance of recurrence. So sometimes it is a cyst and someone goes and puncture it. Yeah, the fluid is gone, the cyst is gone, but it will grow back again because you haven't removed the cyst wall completely. then consider medical treatment after that. Like if you do an endometrioma and you remove the endometrioma and endometriosis, we know that it will come back if you don't put them on the combined contraception pill or you don't put them on the implant or a Mirena. There's some of the physiological cysts, especially if they're recurrent and they're quite big, it is good to put them on a contraception pill if they're not planning for immediate pregnancy. And there's a higher chance of the recurrence for the group that they have a borderline cyst and they need to have regular follow-up with the ultrasound. Okay. Just in terms of the counseling, what do we tell them? In the young patient, it's important to talk about the effect of the cystectomy and the fertility. Depend on the size of the cyst. Then if you do have a 10 centimeter cyst, it's already compressed the rest of the ovary and sometimes it already kills lots of the follicles. And you're doing a cystectomy and you have some bleeding and you kill more follicles, then it can affect someone's fertility. There are different techniques that we use. These days, I do more suturing than using the diaphragm to preserve the fertility to give them a better outcome. Sometimes it's worthwhile doing the AMH before the surgery, especially for the ones that are very worried about the fertility and they have a very large cyst. Just even medical legally, you can prove that it hasn't affected AMH that much. For the ones that they have large or bilateral endometriomas, always consider doing a deep infiltrative ultrasound to look for endometriosis because it helps you a lot to prepare for the operation in terms of, okay, how much we're going to do and if it's going to be bowel involvement or not. Still, laparoscopy is the gold standard approach for a cystectomy and oophorectomy for all the benign condition. What do we do for just a little slide about the postmenopausal woman approach? If you have Adnexal mass, have a look. If it's more than 10 centimeters, refer to gynecologist directly. If it is less than 10, considering doing an ultrasound. I assume that's a mass guessing 10 centimeters, and have a look at other features on ultrasound. If there is suspicious features, send to gynecologist. If it is no suspicious feature, consider doing a CA125. If it is high CA125, or we say more than 35 because you calculate times 3 times 3, you will send it to the gynecologist. If it is low risk, you can repeat the ultrasound in 6 weeks or 3 months. If it is persistent cyst, probably that's when you refer it because if it's persistent, they need treatment. You would think about in a postmenopausal ladies, they shouldn't have a persistent cyst. The ovaries stop working and it is abnormal to have a cyst on a postmenopausal ovaries. You'll be hardly finding the ovaries on ultrasound in the postmenopausal women. Then in a perimenopausal ladies, sort of the same. You make sure that they're not pregnant. Then obviously do a pregnancy test first. If they're not pregnant, you consider doing ultrasound and have a good idea about if it is a complex cyst or not. If it is complex, refer. If it is not complex, again, have a look at the size of it. If it is big, refer it, even if it is simple cyst. If it is not big, then you can consider giving them non-steroidal anti-inflammatory medication, a course of pain relief, contraceptive pill, repeat the ultrasound, and if it is persistent, most likely you should refer them out. Okay, thank you, everybody. I was going to go back to the features of the ultrasounds, and if I have time, then maybe I can ask to see what everybody think about those ultrasound features, and then maybe we can talk about those cases if you guys are interested. Okay. Dr. Forghani, you have to help me. How do I see if people want to make a comment or not about this? Okay.
دوستان میتونن از اون گزینه چت استفاده بکنن. من خواهشم فقط از دوستان اینه که اون گزینه all panelists and attendees رو برای جوابشون انتخاب کنن که دوستان دیگه هم پاسخشون رو ببینن.
اوکی. من چجوری میتونم ببینم؟
شما اگر همون در واقع روی اون چت کلیک بکنید، این
I think I'm sharing the screen. I don't have anything else.
چرا؟ شما اگر بالای صفحه شما تشریف ببرین، اون کرسرتون رو ببرین بالای صفحه، اون یک در واقع دراپ داون میکنه و اونجا چت رو میبینید آپشنشو.
I will do that.
دیدین؟
Still trying.
یا اینکه امکان داره که وقتی که اینو میبرید بالا، روی قسمت مور باید برید و ممکن چت بره تو اون قسمت مور. شما مور رو که برین و چت رو میبینید و چت رو کلیک میکنید. نمیدونم پیدا کردی یا نه.
Okay, yes. I have 6 chats. Yep.
بله، اینا حالا سوالای قبلی بوده. حالا از الان اگر دوستان در رابطه با این تصویر در واقع تشخیصی رو مطرح میکنن همینجا بنویسن تا
من یه ذره راجع به این مریض بهتون میگم ببینم چی فکر میکنین everybody. Okay, then this lady is a 48-year-old lady who presented to the emergency with a severe pain. And she said that she had a history of a cyst, was completely simple, was around like a 7 centimeter a month before that. She was waiting to see a gynecologist, but then all of a sudden she started having this pain. She came to emergency. And probably that's the best ultrasound picture that I've seen in the series that she had. Then looking at this, it is a complex cyst, does have the solid lesion. What do you think? What else do we need? Oh, do I see any response here? Okay, she's not pregnant. She's 50 or 49, 48. She's not pregnant. Promised that one. Not ectopic pregnancy. Beta ICG is negative. Okay. Do you guys want to do any other tumor markers? I assume everybody said yes. Then we did the tumor markers and they're all normal. Like the CA125 was like 25 and all the other tumor markers were like negative. Then the risk of malignancy index would be 3, she's still perimenopausal, times 1 times 20, that was 60. Then it's a low risk, but you look at that and it looks very suspicious. Her hemoglobin was stable as well. Very good point. Who was said torsion? Awesome. Yes. Then it was a tenderness at the time, but the interesting thing, when you actually talk to your radiology friends, they are really helpful. Surprisingly, they called me and said, this solid thing that you can see, when they're doing ultrasound, they said it looks like it's a clot sitting beside this, because she could tell me that they can move this in different direction and it's not attached to this wall. Then that was a good clue. Then what I did, I actually sent that one to a gynecologist friend, because I was like, I'm not going to take her to theatre with the pain if I think it is cancer. And there was no other, it was low risk. But just as a standby, and said, like, okay, most likely she's almost 50, we're going to do a oophorectomy. And it turned out to be just a simple cyst that got torted. It looked completely black and blue. And that was a hemorrhagic area, like it was a clot inside the cyst. The histopathology was benign and it was all good. Now I'm going to go to the next one, if I can. Okay. Now, all the ideas, what do you think this cyst is? Then this is like a 31-year-old lady who had ultrasound because she does have a really painful period. Anybody? It is not solid, despite that it looks like. Who said endometriosis? Yep. It is endometrioma. Have a look, grand glass appearance. It looks all clot like the old blood sitting there. It is a typical feature of endometrioma whenever you see it. Good on all those people that they put endometriosis. Well done. Now, what do you think about this one? This is a 26-year-old lady who had ultrasound just because she wants to get pregnant, and she had a checkup before she got pregnant. And then she freaked out when she saw, oh, there's a cyst in my ovary. Oh my God, who is that person? That's so good. Who said dermoid? Okay, I don't know how to read these names, but whoever said dermoid is the winner. It is a typical feature of the dermoid. You see this shadow, you see the solid cystic lesion, and that is the typical dermoid. What do you think about this one? This is a 56-year-old lady who had some bloating and abnormal bleeding and had ultrasound. I think probably I want to ask if anybody wants to do something else first before come up with the diagnosis. Yes, CA125, brilliant. And it is coming 2,500. And it is endometrial cancer. It is ovarian cancer. Yep. What do you think about this beautiful one? This is a 26-year-old lady who came in with some pain and irregular cycle. And that's by dimension, probably around 4.5 centimeter. I know it looks big. Yeah. Simple cyst, lots of little follicles. And I think I gave you the result from this one. This is a tube ovarian. It's a hydrosalpinx. Okay, you guys have been brilliant. And I have no idea if I talked too fast or was too specific, but more than happy to answer questions. Then while the chat is open, please let me know if you have any question. Dr. Forghani, if there was any other question که من میخواین جواب بدم, just let me know.
یه سوالی بود که قبلا مطرح شد در مورد فالوآپ مریضا بعد از اینکه سیستکتومی میشن و شما فرمودید که باید روی در واقع کانتراسپتیو باشن. سوال به این صورت هست که تا چه مدت بعد اینا باید همچنان روی کانتراسپتیو بمونن، حالا از هر نوعی که استفاده میشه؟
بستگی داره که سیستشون چجور سیستی باشه. Then most of the time اگر که اندومتریوما باشه که you would think about endometriosis other ways, we keep them on a contraceptive pill for a long time and you stop it when they want to get pregnant. اگر که is a fertility thing and اگر که they're past the fertility and they are not planning for pregnancy, just to control the endometriosis not coming back and باعث درد و مشکلات دیگه براشون نشه, you can offer Mirena as a long term, Implanon as a long term, or continue contraceptive pill for a while. اگر که simple cyst باشه, like a physiological cyst, or اینایی بودن که پیریودشون irregular هستش, you just continue it for a while, depend on the age again. Most of the time we use it as a contraception as well, then they use it as a way of contraception. ولی اگه هر موقع که تصمیم بگیرن که حامله بشن یا اینکه if they can't use the contraceptive things, then the chance of recurrence is quite low. اگر که just a simple cyst بوده, physiological بوده. بیشتر are the endometriomas that we're worried about, endometriosis که میخوایم که بذاریشون روی treatment afterwards, or the ones که already irregular cycle دارن and affected شدن به خاطر سیستی که داشتن.
خیلی ممنون. یه سوال ملحت عزیز مطرح کردن که how to diagnose a PID. برای تشخیص PID گفتن که بهترین راه چیه؟
Very difficult. Mainly we go with, clinical story. Typically you find, I don't know, probably I've seen lots of middle-aged girls, ladies coming with a PID these days. Young with the multiple partners, we generally meon with the pain, and you do my manual examination and it is cervical motion tenderness. You touch them and they're very tender, painful. You have a sort of a borderline high white cell count. Depend. There's two types of a PID. There's a sexually transmitted PID and there's a non-sexually transmitted PID. آدم ها میتونن PID بگیرن after hysteroscopy, after a speculum examination, after something که introduce کرده infection بره بالا, and generally they have tenderness, they have pain, borderline, a little bit of the high vital count. اونایی که خیلی مریض باشن و septic شده باشن, obviously you have a high temperature. Most of the time we do a high vaginal swab, and اونایی که positive برگرده برای chlamydia gonorrhea obviously confirm it. Sometimes you have a tube ovarian abscess, that's definitely confirming. Sometimes you have salpingitis that you can see که tuba باد کرده, this diagnosis. Many times we treat them as a PID without having a definite diagnosis. Then you just have a high suspicion of index. Was that helpful or do you need to more?
خیلی ممنون. بله من فکر کنم جواب دادید شما.
Okay, just tell هر کسی که
بله تشکر کردن.
مرسی.
دوستان سوالاتون رو میتونید مطرح کنید، وقت داریم الان. ضمن این که اگر دوستی میخواد که کیسی رو مطرح کنه در رابطه با مریضای خودش و اینها و راحت‌تر است که در واقع بیاد صحبت بکنه، کافیه دستتون بالا بگیرید و من دوربین و در واقع میکروفونتون رو باز میکنم که صحبت بکنید. به هر حال اگر دوستی میخوان که به صورت شفاهی سوالشون رو مطرح کنن، این امکان هست. بفرمایید. این فرصت خوبیه سوالاتون رو بکنید.
I'm happy اگر که if anybody wants to contact me separately and ask about the question as well.
خیلی ممنون. خب ما همچنان منتظر، خب مثل که صحبت شما کاملا همه رو قانع کرد دیگه، سوالی براشون نمونده.
I don't know, it's 9 o'clock at night. Come on, let's go and get some rest.
خب یه سوالی مطرح شده که what pill is good when patient is on contraceptions but still bleeding?
Generally, if they have intramenstrual bleeding, spotting دارن بین period, then you need to change the pill. If depending on what type of the pill you're using, you need to change the dose. Like if you're using something like a macrogynon 20, you might need to go to something like a macrogynon 30 with a higher dose, or you might need to change the estrogen or progesterone component of it. Then there is a good guideline can send you around about. It depends on what's the problem with the pill, what you need to change in terms of اگر you need to change to use a different estrogen or progesterone, which most of the time we change the progesterone type of it, or if you need to actually use a higher dose pill, depend on what is bothering them. The commonest things, if they get nausea, get them to take it at night. But the intermenstrual bleeding and spotting is the main thing they complain, get the unexpected withdrawal bleeding, and you can just increase هرچی که دوزی که دارن مصرف میکنن, just increase the dose of the pill to a higher dose pill for a short period of time, as long as they don't have any contraindication to it.
خیلی ممنون. بله یه سوالی در رابطه با HRT مطرح شده. یه تاپیک کاملا. ولی اگر حالا تو فرصتی که دوستان دیگه حالا میخوان سوالاشون رو مطرح کنن، نوشتن که یه سوال خیلی کلی هست البته که میتونید جواب بدید. نوشتن که about HRT with all side effects, is that wise to try it as GP?
Yes, you have to choose the right person. As long as it's within the first 5 years of the menopause, many times they get good results. You have to just get a good history, make sure they don't have any contraindication, and you give them the combined estrogen progesterone. You can give them the estrogen patch and a progesterone tablet, which probably is the best type to use because I think it is the lowest dose. Make sure you do a good breast check before, get them to check annual breast check, and just watch them carefully. Depend میکنه که symptomation چی باشه. Obviously we use it a lot for the ones که they are young and they go to menopause early in a HRT. ولی اگر که مثلا فقط hot flashes, you can try the natural therapy first. You can try the other treatments besides the HRT to see if that help with the vasomotor symptoms or not. Some people use the clonidine, some people use the SSRIs, and اگر کار نکردش then HRT is a treatment.
ممنون. سوال کردن که is there any difference in treatment of sexual فکر میکنم منظورشون مثلا sexual related PID and posters.
If you think it's a sexually acquired PID, you treat them for chlamydia gonorrhea, then you give them azithromycin and you can send them home, or you give them a stat dose of azithromycin, or you give them the 14 days course of the doxycycline. But if you think it is a non-sexual PID, then you give them like اگر که IV میخوام بدین, you give them cefazolin and metronidazole, you give them Keflex and Flagyl to take home. Then the antibiotic treatment is different.
سوال شده که در این خانم 55 ساله بدون هیچ علامت منوپوز آیا سیف هست که میرنا رو به عنوان کانترسپشن استفاده کنیم؟ نمیدونم
55-year-old که
منظورشون
منوپوز نشدن هنوز.
اینطور نوشتن. بعد
that would be very hard to find someone who is 55 as not menopause.
دکتر دستوری اگه توضیح دارن میتونن اضافه کنن.
Menopause around 51, 52 max. That will be super woman that you find.
سوال شده که what is normal endometrial thickness in women on HRT?
Okay. Postmenopausal ladies, they should have a endometrial thickness less than 4 millimeter. Then regardless of being on HRT or not HRT, you want it to be less than 4 millimeter. For postmenopausal ladies, then we know like HRT and obviously postmenopausal has some. Premenopausal depend on the cycle. Then depend on which part of the cycle you do, endometrial thickness is different. And ideally, you do the ultrasound after they finish the period. The lining of the uterus is the thinnest and the less likely for you to get a false thick endometrium.
سوال شده که آیا is there any specific ultrasound to find endometriosis or always hysteroscopy?
There are lots of new things, and I think the last ages was like the conference was lots of focus on ultrasound features of endometriosis, and I'm pretty sure that all the ultrasound people are running the course. So there are lots of new places that they do deep infiltrative endometriosis scan. That is a transabdominal and transvaginal and the rectal ultrasound. That they have a look at the sliding size. They have a look at how thick and how they say that you can diagnose superficial and deep endometriosis. Then there's a sort of a wave towards now ultrasound is a good way of diagnosing. But if you do a laparoscopy, you diagnose and treat. If you do ultrasound, you diagnose and then you have to send them for treatment. And those ultrasounds are quite expensive. They cost around $500 to get the ultrasound.
خب خانم دکتر دستوری یک توضیحاتی رو در رابطه با اون خانم 55 ساله مطرح کردن. نوشتن که مادر ایشون در 60 سالگی منوپوز شده بوده و این run in the family و ایشون خیلی نگران اینن که حامله بشن و میخوان کانتراسپشن داشته باشن. حالا با این توضیحات
there's no harm. Okay, there's no harm to put a Mirena. You know what? Not only contraception, anyone that has a risk factor of endometrial hyperplasia or endometrial cancer, if you put a Mirena in, it's going to keep the lining of the uterus quite thin and minimize the chance of that. Then not to give her that, even it would help her that she's not going to have the premenopausal irregular bleeding and spotting and heavy periods. Plus, it's going to keep the lining of the uterus thin. There's no harm.
بسیار. پس این انتخاب خوبی بوده.
Perfect.
دوستان دیگه ما 2-3 دقیقه دیگه وقت داریم. پرسیدند دوست عزیزمون is there any predictor who is going to react how to progesterone contraceptive, I guess, as you know people react very differently to them?
Yeah, I think you will get a Nobel Prize if you can see how they react. But sort of you can see from the ones that you can start, I don't know. I don't think you can see how they react, but you can start with the low dose one to see if they tolerate it well or not before. And these days, in terms of the progesterone, we use a lot of Mirenas, and the Mirena is a low dose with less side effect compared to the rest of the progesterone option that we use. Definitely, I don't use implanon that much if I can avoid it because it does have a higher dose. And in terms of contraception, if you're talking about, there's a new IUD called Kyleena, which is a lower dose and a small device to put it in, and does have a lower dose of the hormone, and it's just for contraception.
و این الان در دسترس هستین؟
Yeah. Kyleena is on the market. Yeah.
به عنوان سوال آخر اینجا نوشتن که is there any place for the CT scan in diagnosis of adnexal mass?
Ultrasound is the gold standard if you get a good ultrasound. Sometimes if it's a very big mass and you really cannot see with the ultrasound که کجا تموم میشه کجا داره میره, CT scan can be a valuable thing, especially if you're thinking about mental caking, ascites, other symptoms of the cancer you're looking for lymphadenopathy. And definitely there are place to do CT scan, but that's not the first line treatment or first line investigation to find that. And you have to consider, if you have someone young with a small adnexal mass, probably you're better off doing a ultrasound than doing a CT scan. But if you have someone who passed the fertility age and you have a big mass, then definitely CT scan does have a role.
بسیار خوب. به این ترتیب امشب رو ما به پایان میبریم. دوستان زیادی پیغام‌های تشکرشون رو دارم میفرستن خدمت شما خانم دکتر و من هم میخوام از این فرصت استفاده کنم ازتون تشکر کنم مجدد بابت وقتی گذاشتین. خیلی خیلی ممنون و انشالله حالا باز موقعیت‌های دیگه پیش میاد باز در خدمتتون هستیم اگر شما اینقدر اذیت نشده باشید و باز به ما جواب بسیار عالی. دوستان عزیز تو خونم شبتون رو به خیر میگم و امیدوارم شب خوبی داشته باشید. ادامه این شب رو در واقع و تا هفته آینده با شما خداحافظی میکنم. خانم دکتر از شما هم خداحافظی میکنم. شبتون بخیر باشه.
ممنون، متشکرم. خداحافظ.
خداحافظ.